Good afternoon, everybody. So first, thank you for coming here. The Department of Neuroradiology is going to discuss a case of a rare presentation as far as imaging is concerned of not so uncommon tumor. This is about CNS lymphoma. The presentation will flow like this. The SR from neurology, Dr. Srujana will give the clinical brief, followed by imaging findings, which will be discussed by my resident, Dr. Prithvi. And then the patient was biopsied and neurosurgery. SR Revant will present the biopsy findings. And Dr. Suleiman from neuropathology will discuss the neuropathology. Finally, my resident will come again and continue the discussion before she finally concludes. And in the end, we'll try to take some questions. So over to Dr. Srujana.
Good afternoon to one and all. I'm going to present a case which has presented to our department. This is a 43-year male patient who is right-handed and clerk by occupation and with no comorbidities. He has presented to us with deep complaints of memory impairment since 3 months in the form of forgetting tasks at workplace, and he has stopped going to office since 2 months, and he also forgot the important events of his life, and he had decreased interest in daily activities, and now he was dependent on others for his activities of daily living since 1 month. And behavioral disturbances, he had compulsive eating, hyperphagia, and agitated behavior. And on examination, on presentation, he was conscious, disoriented, and he was agitated with irrelevant talk. General examination was normal, and the rest of the system examinations were normal. And coming to the neurological examination, the cranial nerve examination seems to be normal, with fundus was normal. Motor system examination, there was no paucity of movements of the limbs, and the reflexes were normal, both the deep tendon reflexes and superficial. Plantars were bilateral flexor responses. Sensory, he was responding to painful stimuli. Cellular signs and gait could not be assessed because of his sensorium, and meningeal signs were absent. With a provisional diagnosis of rapidly progressive dementia, we have planned to work up further regarding towards the etiological. And coming to the workup, his routine workup, including the routine blood workup and chest X-ray were normal, and other workup which were for rapidly progressive dementia, including vitamin B12, thyroid profile, anti-TPO, and viral markers were normal. And CSF analysis was done, which included proteins of 62 milligram per deciliter and sugar 64 out of 111 RBS, and TLC, which was 60 per millimeter cube with 50% monocytes and 50% neutrophil. And the rest of the infectious workup in the CSF was negative, including the tuberculosis, fungal, and bacterial. Flow cytometry did not show any clonal lymphoid cells, and we further went on to look for the imaging of the brain and also PET scan. That PET scan was showing active lesions in the brain, and further the imaging will be discussed by my colleague, Dr. Prithvi. Thank you. Good afternoon, everyone. With the following clinical details, we have performed contrast-enhanced MRI brain on 18 December 2020 in our institute. Here we can see these are axial flare sections showing multiple flare hyperintensities involving periventricular and deep white matter of bilateral cerebral hemispheres. And at places, the flare hyperintensity is seen involving the subcortical white matter in the left temporal lobe. There is also involvement of the corpus splenium body of the corpus callosum, and also periventricular region of the fourth ventricle in the posterior fossa. And there is involvement of the bilateral thalami, posterior internal capsules, and posterior putamen along with the white matter. Flare hyperintensity is also seen in involving optic chiasm, bilateral optic tracts along with white matter, and few subtle flare hyperintensities are also seen in bilateral cerebral peduncles. There is involvement of the pons, cerebellar peduncles, medulla, and white matter of bilateral cerebellar hemispheres. And subtle flare hyperintensity is also seen in cisternal segment of right trigeminal nerve as compared to the left one. Sagittal and coronal sections better depicting the extent of involvement. Here we can see involvement of the body and splenium of corpus callosum, optic chiasm, brainstem, and periventricular and deep white matter of supra and infratentorial locations. These hyperintensities are iso to hypointense on T1 weighted images in periventricular region and in the corpus callosum, and also in the region of optic chiasm and brainstem. Altered signal intensity is seen in the form of heterogeneity on T2 weighted images, predominantly hyperintense, but not to the extent of CSF signal. Few areas of hypointensities are also noted in periventricular region and in the corpus callosum. And heterogeneity is also seen in posterior fossa. Coronal sections better depicting the extent of heterogeneity on T2 weighted images in supra as well as infratentorial locations. And diffusion restriction is seen predominantly in the region of corpus callosum. And no abnormal susceptibility weighted foci are seen. No abnormal blooming foci are seen in susceptibility weighted imaging. On post-contrast study, we can see a few patchy nodular foci of enhancement in the periventricular region as well as in the region of corpus callosum. And subtle enhancing foci is seen in the right cerebellar hemisphere, and coronal sections better depicting the extent of involvement, predominantly involving the corpus callosum and the periventricular location. On MRIs, there is elevated choline-creatine ratio is noted with presence of lipid and lactate peaks. Coming to the cerebral blood volume, R10 is the ROA drawn in the region of non-enhancing area, which shows RCBV of 69, whereas R9 is the ROA drawn in the region of enhancing location, which shows RCBV of 192, ratio being 2.4. On perfusion study, elevated cerebral perfusion is seen, which is not reaching to the baseline. Spinal cord imaging shows no abnormal leptomeningeal enhancement. Grossly, the spine is normal. On NCCT, the lesions are predominantly hypodense in the periventricular region as well as in the corpus callosum, except in the region of the corpus callosum and in the periventricular region where it is seen as iso to hyperdensity, which is corresponding to the areas of enhancement on the post-contrast MRI study. In summarizing the findings, multiple asymmetrical confluent flare hyperintensities involving the periventricular demyelination is predominantly a white matter disease. And coming to the pattern of enhancement, both the entities will show patchy enhancement, but however in demyelination, few of the lesions, that is only active lesions, will show enhancement. And coming to the diffusion weighted imaging, again in demyelination, the active lesions show diffusion restriction predominantly in the peripheral location, whereas in lymphomatosis cerebrae, minimal or absent diffusion restriction is noted. On SWI, in demyelination, there is presence of central vein sign because of the perivenular inflammation. The hyperintensities will show presence of central vein within the flare hyperintensity, whereas in lymphomatosis cerebrae, no susceptibility changes are seen. On spectroscopy, in lymphomatosis cerebrae, lipid peak is seen in the absence of necrosis, whereas in demyelination, glutamine peak are seen at low TE. And coming to the RCBV, lymphomatosis cerebrae will show relatively higher RCBV, whereas multifocal demyelination will show low RCBV. In our index case, RCBV cerebral blood volume was ratio of approximately 2.4, and spectroscopy findings showing presence of lipid peak in the absence of necrosis, and with absent susceptibility weighted changes with presence of diffusion restriction and patchy enhancement, and involving gray matter as well apart from the white matter. And diagnosis of primary CNS lymphoma has been considered, and repeat MRI under IGS protocol was done on 12 January. And here again we can see the presence of multiple flare hyperintensities involving periventricular white matter, deep white matter, as well as deep gray nuclei, and coronal and sagittal section demonstrating the same. And as compared to the previous MRI, there is subtle increase in flare hyperintensities in the region of white matter in bilateral cerebral hemispheres. And also there is presence of an new enhancing foci noted in the left temporal lobe. And then patient was posted for biopsy, which was discussed by Dr. Revanta.
Thank you, Dr. Prudvi. Good afternoon, everyone. Today I'll be discussing the intraoperative course of this patient. Based upon the MRI which was done on 12th of January, which was showing enhancement lesions mainly in the periventricular region in the corpus callosum. We have used intraoperatively image guidance system and neuro navigation, and we have planned a safest trajectory to avoid major blood vessels and main important structures, and we have chosen the supraparietal lobule. The trajectory was planned at around 40 millimeters from the burr hole which we have done during the surgery, and a total of 6 samples were taken, among which 2 were from were overshoot and 2 were within the lesion and 2 were undershoot. And 1 sample was sent for frozen, which came out to be normal tissue, but still, as we have taken from the site of the lesion, all the remaining 5 they were sent for histopathological examination. This is the image guidance system machine which I have used for taking biopsy. This is sorry, we didn't take the intraoperative video, so this is just the demonstrative video of taking the biopsy. In this, actually, after planning the trajectory and planning the proper trajectory, we have infiltrated the scalp with the lignocaine and ADR, and then the burr hole is planned at the same site, and after marking a point on the cranium. So once the burr hole is done, and then after again confirming the trajectory with image guidance system and navigation, the dura is opened in a cruciate manner and then coagulated. Using this vertex Medtronic system, we have taken biopsy from the lesion. The trajectory was around 4 centimeters in our case, and using negative suction from the syringe, we have taken around 6 samples in this case. And then it was placed in formalin and sent for histopathological analysis. So now I would like to invite Dr. Suleiman to discuss the histopathological examination.
Very good afternoon, everyone. So we have received 5 brain biopsies. Out of 1 shows only blood clot, and rest of the biopsies, when we examine, it shows a cortical brain parenchyma, which was infiltrated by these large atypical cells along with surrounding reactive gliosis. And these cells were strongly immunopositive for CD20 membranous, and it was showing some reactive T cells like lymphocyte positive for CD3 as well. So in order to subclassify further, we have, like, according to Hans' algorithm, we have performed CD10. So this is CD10. CD10 was negative. Then we have put up BCL6. BCL6 was showing nuclear positivity in those large atypical cells, and then MUM1 positivity. And OLIC2 was like highlighting the reactive glial cells. And so EBV is negative. So summarizing the finding, the cortical brain parenchyma infiltrated by large atypical cells, which was positive for CD20 and BCL6 and MUM1. And we have rendered the diagnosis of primary diffuse large B-cell lymphoma post-germinal type.
Thank you, Dr. Suleiman. I'll be discussing a brief review of the primary CNS lymphoma, and a few important points I'll be discussing in the imaging of typical lymphoma, in lymphoma and immunocompromised, primary versus secondary lymphoma, and few points of lymphomatosis cerebri and effects of steroids and lymphoma. The typical classical imaging features of primary CNS lymphoma, generally they are solitary with predilection to the deep gray nuclei, periventricular white matter, corpus callosum. In 75% of the cases, they will be contacting the CSF surface. On NCCT, they are hyperdense because of high cellularity and nuclear cytoplasmic ratio. And necrosis and hemorrhages are very rare, and they are commonly seen in immunocompromised patients. And calcification again is very rare and seen in cases of prior chemotherapy and radiation. And edema and mass effect are very less. And typical lymphoma shows dense homogeneous enhancement, and the areas will be corresponding to the flare hyperintensity. In advanced MRI imaging, the typical lymphoma shows diffusion restriction, strong diffusion restriction, and show low maximum cerebral blood volume. And on MRIs, elevated choline lipid lactate peak will be seen, and also the presence of lipid peak in absence of necrosis is seen in typical lymphomas. And on SWA, calcification and hemorrhages are rare. As compared to the immunocompetent individuals, the immunocompromised patients will present relatively in younger age group with presence of and multiple lesions are more common in immunocompromised patients, and necrosis and hemorrhages are common as compared to immunocompetent, and also the enhancement pattern is heterogeneous. And multifocal white matter involvement, presence of multifocal white matter involvement in immunocompromised individuals, we can consider the possibility of PML, progressive multifocal leukoencephalopathy. But in PML, we can see there is absence of enhancement, and diffusion restriction will be seen according to the disease stage. And the active lesions will show incomplete rim of diffusion restriction. And coming to the primary and secondary lymphoma, primary CNS lymphomas are rare with incidence of 3%, whereas secondary CNS lymphomas are much more common than primary. In primary, in almost all the cases, brain parenchyma involvement is seen. It is called as parenchymal CNS lymphoma also. Whereas in secondary CNS lymphoma, brain parenchyma involvement is seen in only 1/3 of the cases, and 2/3 of the cases it is leptomeningeal involvement. It is called as leptomeningeal CNS lymphoma. Rest of the signal characteristics are same, only the predilection for the site of involvement is different in both primary and secondary lymphoma. And effect of steroids. Steroids will cause apoptosis of the B cells, and they cause tumor regression and lysis. And sometimes it causes complete disappearance of the tumor, which is called a ghost tumor. And after giving administration of the steroids, there is reduced or absent enhancement is seen because of the normalization of the blood-brain barrier. It does not indicate the therapeutic response. Non-enhancing tumor progression is seen in the form of T2 or flare. And on discontinuation of the steroids, again there is enhancement can be seen. The steroids will cause resolution of the diffusion restriction, but it does not cause any elevation of the cerebral blood volume. Coming to lymphomatosis cerebri is the rare variant of primary CNS lymphoma, in which the presents with abnormal behavior, personality changes, and rapidly progressive dementia. And on imaging, extensive diffuse T2 flare hyperintensity of white matter without formation of cohesive mass is seen, and they show patch or absent enhancement and minimal or absent diffusion restriction, which are all seen in our present case. And lymphomatosis cerebri is a rare variant of primary CNS lymphoma, which mimics the multifocal demyelination. And advanced MR imaging helps in diagnostic confidence. However, histopathological diagnosis still holds the gold standard. Thank you.
So thank you all. Are there any questions?
Any history of treatment before the
Patient is
Before imaging, there was no history of any intake of steroids.
I think steroid was given. It was given
steroid was given.
4 weeks almost.
Okay. So we had a repeat MR, but it didn't show any regression. In fact, there was progression in the imaging findings. The one which was done on 12th of January, there was definitely progression.
But you said there was a therapeutic response. There was steroid effect on the inner.
Oh, yes, sir.
There is not therapeutic response. What do you mean?
Means the tumor doesn't go away, it's still there, but the enhancement pattern disappears because there is healing of the breach in the blood-brain. This is what she's trying to say.
Because they're admitted in neurology.
Patient was admitted under neurology. workup done from the neuroradiology side and finally referred to neurosurgery.
Before they give COVID.
Yes, yes.
Actually, patient was rapidly deteriorating. He presented
Dementia.
nephropathic, then he became deeply comatose before we thought.
Mm.
He became E1 BT M2 state.
Mm.
It was,
Why don't you come here? Please come.
before he could reach to M2 state, so in view of rapid worsening of clinical state, we had to give him steroids as a rescue measure. But anyway, when we posted for biopsy, still showed a confirmatory.
Okay. But did he improve with steroids?
No, he didn't improve his steroids, but after biopsy, then after confirmatory, he is on CHOP regime, but he still to state not shown any improvement, probably because of the extensive.
Maybe the disease is very extensive. Any other question? So I conclude the case. Okay. Over to Dr. Pankaj.
I don't know. But you are a better person to decide about the steroid. But people say that steroid should be stopped for 2 weeks at least before you take the biopsy. And brain biopsy is very difficult to convince anyone. But the biopsy should be first. If you have strong suspicion of radiology, biopsy should be the first test to be done. Because most of the cases we are not able to give the diagnosis. It disappears, lymphoma. And there's some people, they have shown that within 12 hours, lymphoma disappears. It's very, very difficult to diagnose after steroid. This is
Sometimes we have this.
this is very interesting because in the frozen, we thought this is normal brain. There were some cells which are looking more pleomorphic. And even in the routine, the first test they have done the OLIG2, which is a marker for the glial cells. And after that, I think Rohit Bhatia talked to me. Rohit Bhatia was the
No,
someone was involved. He said that this AIIMS, I don't know. Someone said the AIIMS is strongly suspecting lymphoma. Then these LCA and the CD20 they were done. It's very classical of the cerebral. This is what you said. But now WHO says that this term should not be used.
Yeah.
The reason is only one, because after steroid therapy, normally your lymphoma present like a tumor, mostly, and they go to neurosurgery. They are very easy to diagnose. The one which present like this, which those patients who go to neurology, they get a lot of steroid and very difficult to diagnose. Lymphoma disappears. So I'm just this is one of the.
for the biopsy to.
So most of the time, the steroid mitigated lymphoma versus this entity is difficult to differentiate. And prognostically, there is no difference between the two. So that is the one reason that WHO says they should not be. But this patient doesn't have any immunosuppression.
No.
What is the immunocompetency?
Competent. In India, most of the patients are immunocompetent
Yeah.
as compared to the Western literature. And most of the patients, pardon? CD4, practically you can say they are very low. In one case you must have seen the CD4 count less, but usually it is not. And the age is also a decade earlier in India. This patient is 42. I think in Western literature, seen up in 60s, most of the lymphomas. In our country, in 60 cases, we have done this Epstein-Barr virus. Only 3 were positive.
So
So it's very low incidence of immunosuppression. Most of them, the LMP positive, this Epstein-Barr virus are usually in the immunosuppressed HIV or renal transplant.
Does steroid have any influence on histopathologic changes?
Yes,
this is what is trying to highlight, that the steroid will have influence on the
most of the cases, there are a lot of actually it is the pathology reputation is at stake. You will go to one pathology, you will say this look like lymphoma. The others say, no, 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 this is not a lymphoma. Cells disappear. Nothing is there. Only mature looking cell. And in CNS lymphoma, usually also, you get the CD3 more as compared to CD20.
Ideally, if there is a imaging report of lymphoma, you should consider it to be an emergency and do an emergency.
Well, that may be one point of I think discussion here, but I think why steroids were given, because the patient was rapidly deteriorating. That's why they were compelled to give steroids. Otherwise, ideally, yes, when lymphoma is suspected, we should withhold steroid first till the biopsy is done.
Yeah, when he was plant biopsy, we stopped the steroid. Whenever we got the plant or biopsy, we decided for biopsy because it was highly suspicious, and even if for the IGS protocol MR also it was showing still enhancing lesions. So we said, let us go for the biopsy.
Okay, so thank you very much. Please come here because you will not be audible.
There are recent studies saying that withholding steroids before biopsy, as mentioned in the previous literature, could not be favorable in some patients where it is required. So a study showing that in which they included histopathological diagnosis of primary CNS lymphoma, preoperatively given steroids, among which 15 patients were there, and among 13 patients have proven to be histopathologically lymphoma, even on giving steroids. So that is a study from Journal Cancer Neurology. So recent evidence.
They have two presentations. One is as SOL. Maybe those cases with SOL, they go to their symptoms, space occupying lesions. Their symptoms, you give steroid, they will not respond as well as the other are which like presenting like this, diffuse involvement. Those are the one where steroids are. I remember one doctor, he was in Saudi. They did the biopsy and they said this is encephalitis. Then they took the biopsy to Niman. They said this is a viral. Then brought here. We also said this is encephalitis. And after they repeated another biopsy, that again he was on steroid. Again it was diagnosed as encephalitis. And I think third biopsy, radiologically, they said this looked like lymphoma. And third biopsy proved it was a lymphoma. So those which are presenting a diffuse disease like this, they respond to steroids.
Sir, one more point, please. I think also before biopsy, we also try to take as much as possibility of diagnosing through CSF, because CSF also has a good yield, because many times from pathology we have got few CSF positive. So before posting for biopsy also, in which there are mass SOL lesions, we try to do at least 1, 2, at maximum we have done almost 3 CSF also to see for confirmation of diagnosis before biopsy. But also we will be very happy that the biopsies, they give definitely confirmatory diagnosis. So we expect biopsies will continue to confirm.
I think wherever there is a meningeal, leptomeningeal enhancement or subependymal enhancement, there the yield is going to be little higher in CSF studies. So this is my take. Of course, there might be difference of opinion, but it's okay. Thank you. Over to Dr. Pankaj.